about epidemiology of COVID-19 in the US in general, and then talk about COVID as an occupational disease. Then I'm going to talk about public health surveillance for COVID among workers in the US and some examples of other evidence on occupational risk factors for COVID. So as you know, COVID is caused by the virus SARS-CoV-2, which was first identified in Wuhan, China in December of 2019. And the first US case was reported on January 21st, 2020, over a year ago. WHO declared the global pandemic on March 11th. So where are we now? This slide shows some screen clippings from the updated CDC COVID data tracker that I pulled yesterday. And you can see at the top that as of February 17th, over 27 million total cases and over 480,000 total deaths had been reported to CDC. Below the numbers, you can see the variation in recent incidence rates by county on the left, and on the right, you can see the epi curve that shows the number of new cases reported by day. And CDC updates all of these statistics and more daily. Now, since this is an occupational medicine symposium, let's talk about COVID-19 as an occupational disease. So back before COVID-19, I worked with Cha-Ping Su from Taiwan CDC, who was completing the EIS program with NIOSH at the time and other NIOSH colleagues to write a synopsis about case investigations of infectious diseases occurring in workplaces that was published in the journal Emerging Infectious Diseases in March of 2019. In this paper, we described disease factors, workplace factors, and worker factors that may contribute to transmission of infectious diseases in workplaces. And we found that the current spread of SARS-CoV-2 is related to many of these factors. And you may have seen this recent article in the American Journal of Industrial Medicine that confirms this and talks about some of the workplace factors for COVID-19 as an occupational disease, described in the article as what makes vulnerable workers, which includes exposure to infected aerosols, lack of PPE, high worker density, poor ventilation, and inability to social distance. Then there are worker factors that make for susceptible workers, including demographic characteristics, comorbidities, and co-exposures, and cross-cutting factors that affect many groups of workers, including limitations to housing and transportation, socioeconomic factors, and access to paid sick leave and healthcare. So some of the disease factors that make SARS-CoV-2 so good at spreading in workplaces are that the virus is very contagious due to high levels of shedding in the upper respiratory tract, and pre-symptomatic people are infectious 1 to 3 days before symptom onset. That's the big thing that we didn't recognize at the beginning, was about the infectiousness of pre-symptomatic people and the fact that many infected people may never experience symptoms or remain asymptomatic but are still capable of spreading the virus. And because of these factors, preventing workplace transmission requires layering multiple mitigation strategies, which I think we'll hear a lot about today. So OSHA has described the occupational risk for COVID-19 using a pyramid based on job tasks from lower risk at the base in blue to very high risk at the top in red. And the categories of job tests in the pyramid are based on industry type, the need for contact within 6 feet of people known to be or suspected of being infected, and the requirement for repeated or extended contact with persons known to be or suspected of being infected. And specifically, the very high category includes healthcare personnel performing aerosol generating procedures, healthcare personnel or laboratory personnel performing specimen collection and handling, morgue workers performing autopsies, whereas the high category includes other frontline healthcare personnel, medical transport workers, and mortuary workers. And the medium category is based on that frequent or close contact with people who may be infected with SARS-CoV-2, but are not known or suspected COVID-19 patients. So in areas without ongoing community transmission, this includes things like contacts with travelers. But in areas with ongoing community transmission, as most of the US is right now and has been for a while, this includes contact with the general public, including coworkers. And then the lower risk caution base of the pyramid is workers with minimal occupational contact with the public and other coworkers, which right now is mostly workers who work completely from home. So now I'm going to talk about the surveillance for COVID-19 among workers in the US. So on June 11th, some colleagues and I posted a series of NIOSH science blogs to describe the status of collecting occupation and industry data for COVID cases and some of the challenges associated with collecting, coding, and analyzing these data. Some progress has been made since then, but unfortunately, we still do not have comprehensive surveillance data on COVID-19 cases among different groups of workers in the US. The group of workers that we do have the most data about is healthcare personnel. And as shown in the lower right of the slide, we published a first summary of characteristics of healthcare personnel with COVID that had been reported to CDC as of April 9th. An updated report was published in MMWR in September. After the initial MMWR report, CDC began reporting daily updates of the number of reported healthcare personnel cases and deaths online. And so, as shown as of February 17th, there had been over 400,000 healthcare personnel cases and 1,423 healthcare personnel deaths reported to CDC. However, this is definitely thought to be an underestimate because healthcare personnel status was only available for less than 20% of the cases reported to CDC by the jurisdictions. So as you probably all know, another work setting that has been receiving a lot of attention because of reported outbreaks is meat and poultry processing facilities. And CDC has published a few reports on this industry, although nothing too recent. So as of May 31st, there were over 16,000 cases and 86 COVID-related deaths that were reported to CDC by the jurisdictions from 239 affected facilities in 23 states. And they found that the risk of disease transmission was attributed to structural, sociocultural, and economic factors, including structural and operational practices that limited options for social distancing, difficulty performing job tasks while wearing face coverings, challenges adhering to additional cleaning and disinfection guidelines, language and cultural barriers, and incentivization to work while feeling ill. So this all came from outbreak investigations. Another data source that CDC has been using to look at the impact of COVID-19 is media reports. And under the Community Social Impact tab of the CDC COVID data tracker, you can look at clusters or outbreaks that have been reported in the media, including outbreaks associated with workplaces. So this is just a snapshot from yesterday, and the example shown over on the right talks about a cluster among employees at Old Dominion University. So that's just one way to look at some of the reports of workplace clusters. There have been a few state-specific reports about workplace exposures or workplace outbreaks. For example, a group in Colorado looked at workplace exposures reported by cases identified prior to stay-at-home orders issued on March 26th, and they found that 47 of the 99 cases with known infected contacts, or 47%, reported exposure in the workplace, and that the most common work settings for reported exposures were healthcare, a professional or office setting, public administration or armed forces, and manufacturing, including meatpacking. Another group in Utah summarized workplace outbreaks that were reported in Utah between March and June of 2020, and they found that 210 of 277 COVID-19 outbreaks that were not healthcare occurred in non-healthcare workplaces. And 58% of the cases in these outbreaks were in 3 non-healthcare sectors: manufacturing, wholesale trade, and construction. They also reported that Hispanic and non-white workers accounted for 73% of workplace outbreak-associated cases and only made up 24% of all workers in the affected sectors in Utah. So one of the first kind of comprehensive US reports of the distribution of reported cases among workers by industry and occupation came from Washington State. And so as of September 13th, they looked at 80,093 lab confirmed cases, and 30,895 of these had employment information that was codable to standard occupation and industry codes. And they found that 2 sectors were overrepresented among cases versus the Washington employed population. The first of these, not surprisingly, was healthcare and social assistance, and the second was agriculture, forestry, and fishing, which made up 11% of the cases but only 3% of the workforce. Another report that came out is from Michigan, looking at COVID-19 deaths by industry as of June 23rd. And they looked at 1,822 Michigan COVID deaths who were of working age, ages 18 through 70. And they found that the largest number of COVID-19 deaths among workers were in manufacturing, healthcare, and retail trade. But the highest mortality rates were among workers in the military, other services, and transportation industries. So on the left, you can see that California has been reporting COVID-19 worker compensation claims. And as of January 25th, they had 110,107 total claims and 545 deaths. The chart excludes denied claims, and the denial rate ranged from 17.9% in December to 43% in March. In California, COVID-19 illness is presumed to be work-related if you reported to your employer's worksite between March 19th and July 5th, 2020. You are a first responder or healthcare worker in contact with COVID-19 patients, or you test positive for COVID-19 during a COVID-19 outbreak at your workplace. So some of the distribution here is related to the presumptive work-relatedness rules, but it's interesting that they do have accepted claims in many different industries in addition to healthcare. And then on the right are some bullet points from a mortality study in California. And they looked at death records aged 18 to 65 and found a relative excess of COVID-19 mortality, 39% excess overall for food and agriculture workers, but this was up to 59% when limited to Latino workers and 16% among white workers. They also found 28% overall excess mortality for transportation and logistics workers, 36% for Black retail workers, and 40% for Asian healthcare workers. So those are some of the general surveillance-based data. Now here's some examples of other evidence on occupational risk factors. And I definitely don't have time or the bandwidth to cover everything that's out there, but here are a few highlights from articles that I found interesting. So there have been several studies published that describe the distribution of hypothesized risk factors for workplace exposure to SARS-CoV-2. And some have been based on the Department of Labor's Onnet database, which contains hundreds of standardized and occupation-specific descriptors on almost 1,000 occupations covering the entire US economy. So the table shown here is from a paper by Baker et al., estimating the burden of United States workers exposed to infection or disease that was published in PLOS One in April. So these are the occupational groups that were most likely to report being exposed to any infectious disease at least once per week or month prior to the COVID-19 pandemic. Note that protective service includes police officers, firefighters, and transportation and security screeners, and personal care and service occupations include child care workers, nannies, and personal care aides. Community and social service occupations include probation officers, community health workers, and social and human health assistants. So Dr. Zhang used the Washington report that I mentioned earlier and the Onnet analysis that I just described to model occupational risk, and found that the prevalence by occupation in the Washington report correlated with the Onnet data to build a regression model to predict individual occupations at greatest risk. And two variables that correlated with case prevalence and predicted 47.5% of variance were the disease exposure variable described in the previous report, and also a physical proximity at work variable. And the highest risk occupations, according to this analysis, are in healthcare, particularly dental, but there were many non-healthcare occupations that also appeared to be vulnerable. And these included workers who are either in close contact with others, such as flight attendants, teachers, barbers, jailers, and transportation security screeners, or those who may be directly exposed to SARS-CoV-2, such as ambulance drivers, morticians, and embalmers. But the author did note that recent measures such as social distancing and remote working may not be reflected in these predictors. And this table summarizes a case series by Lan et al. That describes work-related COVID-19 transmission in 6 Asian countries or areas. And this is from early in the pandemic, but what's interesting about that is that at that time, the caseload was low enough that they were able to investigate work-relatedness of cases. And so they looked in these countries or areas for 40 days after the first locally transmitted case and found 103 possible work-related cases out of 692 cases, so 14.9%. And these occurred in many different occupations, including health professionals and drivers in transport, and several others shown there. So another study that came out talks about the risk of COVID-19 among frontline healthcare workers versus the general community. And so this is a prospective study of more than 2 million community members in the US and the UK in March through April 2020. And based on self-reported data, including symptoms and test results from the COVID Symptom Study smartphone app, they found that healthcare personnel were 3.4 times as likely to be diagnosed with COVID-19 as the general public. And that was after adjusting for the increased likelihood of these workers receiving a test. They also found that Black, Asian, and minority ethnic healthcare personnel had an increased risk of COVID-19 compared with non-Hispanic white healthcare personnel. Another interesting study is from Norway, because they had pretty comprehensive data on the industry and occupation of their COVID-19 cases. And they found that during their first wave in February through July of 2020, while there was limited testing and a national lockdown during part of it, they found that nurses, physicians, dentists, physiotherapists, bus, tram, and taxi drivers had 1.5 to 3.5 times the odds of infection compared to all working age adults. Whereas in the second wave, from July through October, when there was expanded testing and more targeted mitigation measures and a less steep wave of new cases, they found increased odds of infection among other worker groups like bartenders, waiters, food service counter attendants, taxi drivers, and travel stewards. So in conclusion, we know that the COVID-19 pandemic has had major effects for workers, and that some groups of workers, including healthcare personnel, have increased risk due to patient contact, while other groups of workers, such as meat and poultry processing workers, have increased risk due to physical proximity to coworkers or the public. And occupational risk may be influenced by disease factors, workplace factors, and worker factors. But for many reasons, estimating the actual degree of occupational risk is challenging, and increased collection and reporting of occupational data are needed. And here's some links to go for further information. Of course, the CDC COVID-19 website is being updated daily, and there's a lot of information there, and there should be more updates coming out soon. And I just wanted to acknowledge some of the people and groups that helped me to do the literature review and put these slides together. Thank you.
Great, thank you so much. We have time for some questions. So if you have a question, please type it into the question and answer, the Q&A box. Dr. Luckhaupt, what are some of the lessons learned from the initial COVID response, and how can they inform future responses to protect workers from infectious disease outbreaks?
Well, so I'm sure there's going to be plenty written about lessons learned, but one of the things that's pertinent to this talk on the epidemiology is just the importance of collecting good data on what's going on among workers and in workplaces, because it's really hard to tell how workers are being impacted if we're not collecting good data, and then continuing to collect data on the impact of mitigation will be important.
Thank you. Where does aerosol and airborne transmission fit into the risk pyramid, and why or why not?
So that risk pyramid was developed a long time ago, and it may be updated, but it seems to me that since it's based on exposure to patients and to the general public with disease, that aerosol transmission fits in there somewhat, but there is that emphasis on 6 feet, which is something that may be adjusted.
Thank you. Does the CDC have any data on the prevalence and rates of COVID in the prison system?
Yes, so within the CDC COVID-19 response, the people who are incarcerated are mostly looked at by the Community Intervention and Critical Populations Group. And they have looked a lot, mostly based on outbreak investigations, and then also tracking data from outside organizations that look at case rates among both the people who are incarcerated and the staff.
Thank you. Is there any guidance to encourage the collection of occupational data for every identified case? Could that field be added to testing forms as a standard practice, at least for programs that are run by employers and institutions?
So that's where I feel like we've made a lot of progress in having those fields added to case investigation forms, but they've always been optional so far. And so that's the problem, especially with the volume of cases that are being reported. The optional fields don't often get filled out. And so that's why the data are very incomplete.
Where do you recommend that businesses turn to for more customized advice?
Well, CDC and NYNJ have produced some fact sheets for various types of industries, and some of those are being updated right now. But if they need even more customized advice, then they should, I think, first start with their jurisdictional public health programs, who will then consult with CDC and NYNJ if needed and able to provide more specific advice.
Are we finding a correlation between occupational exposure in healthcare settings and the increase of community spread?
There's definitely been a correlation found between cases among healthcare workers and the level of community transmission. It's hard to tell the exact direction of that. That can go in both directions, I think.
And why is CDC recommended KN95 respirator as a face covering? This policy creates issues in workplace setting where voluntary use of respirators are not allowed.
Yeah, I think the differences between respiratory protection with certified respirators and the use of face coverings has been, really complicated in this pandemic. And I think there'll be more guidance coming out about that soon.
Okay. In terms of collecting data about illness, are there any reliable sources of socioeconomic data other than race, gender, and ethnicity? For example, income or job status within an industry, white collar, blue collar, et cetera?
So I'm trying to think about that. I mean, we definitely know characteristics of the workforce in different industries with regard to their income and other socioeconomic factors. But on the case reports, we aren't getting much beyond gender and race and ethnicity, and even the race and ethnicity data has had some limitations.
All right, thank you very much.